seconds, please.
Yes, sure. So 30 seconds, we will be online. We will be live.
Correct. I have given the permission for attendees to join. You may start now.
Shall I, Shweta?
Yes, sir, sure. We can.
Good evening, ladies and gentlemen. Welcome to another exciting and enriching episodes of Secrets of Neurology. This is episode number 53rd, which means we have already crossed 4.5 years. This has involved more than 40 plus institute, 53 interesting case discussions, and all of it is now a part of our archive. Any student can take access to the same. We are extremely fortunate and grateful to our two patrons, mentors, and course directors, Dr. Sudhir Shah and Dr. Lakshmi Narasimhan sir. Their untiring effort, innovation, and connect with the neurology fraternity has brought this. We all know that this program starts at 8 o'clock and we try finishing and winding off by another 1 hour. My honor and privilege to briefly introduce both our program directors, who is very well known to us, Dr. Sudhir Shah, Professor and HOD at prestigious SMT, NHS, MMC, SBPI, MSR, Ahmedabad. Dr. Sudhir Shah is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. He has many accolades. I would mention only a few. He's author of 6 books on neurology. He is recipient of many laurels. Very recently, he was also awarded the French Senate Paltussi de Luxembourg, Paris, France, which is the highest international award for Indians. He has also been conferred Padam Shri in the year 2016, and is also recipient of BC Roy Award. Dr. Sudhir Shah's interest is into stroke, neurodegenerative disease, and epilepsy. Who doesn't know our second program director, Professor Dr. Lakshmi Narasimhan Ranganathan sir? Sir is currently Director and Professor Department of Neurology at prestigious Sri Ramchandra Institute of Higher Education and Research, Chennai. Before than this, sir also went on and created a state-of-art neurology center, Madras Medical College. Many awards and affiliations, Paltussi Advisor, A.B. Bakers Award, Best Papers Award, but all this is wonderful. In addition to this, the number of students and support he has provided to the field of neurology is immense. Sir, we are extremely grateful to you for leading this entire Secrets of Neurology. May I request both our program directors to take it forward from here.
Thank you. Can I have the next slide, please?
Sure, sir. So it's on your screen?
Yeah, it's not there. Try to share the slide.
Shweta, go into the individual slide, which sir can read. Yeah.
Professor Madhu sir is one of the doyens of neurology in Indian neurology field. One of the greatest clinical neurologists in the country has ever produced. You know, sir has been a sheet anchor for any neurology program in the country, and I'm yet to see a better clinical neurologist in my life. I am fortunate that I'm associated with him for all these 20 years. I'm very grateful, and I requested, because the entire country should be benefited by his acumen, clinical acumen and knowledge. That's exactly why I personally requested him to be part of this session. My next sincere gratitude and thanks to Professor Shaji from Alappuzha Medical College, where recently in the CAN teaching program, he produced an array of fantastic clinical cases. I was part of that. I was excited. And we have chosen 2 pearls, one today and one next month. And they will be part of the our neurology secrets. And thanks to his kindness that he gave permission for this clinical discussion, I welcome Professor Shaji and Professor Madhu sir. And I hand over can I have the slides, please, Shweta?
Sir, it's on your screen, Dr. Nitya Josh.
Yeah, just see. Dr. Nitya Jose, MBBS 2013, Government Medical College Trivandrum, MD General Medicine 20, Ernakulam, and I've seen her presenting in the recent CANs. Welcome you, Dr. Nitya.
Thank you, sir.
Next slide. Shaji sir, Professor HOD of TD Medical College, Jalapura, MBBS from 1997, MD General Medicine from the same college, DM Neurology from NIMANS, and MPhil Behavioral Science from MG University. And awards, Bhaskar Verma Memorial Award, Best Doctor Award for Health in Foundation IMA, Best Doctor Award from the Sadhujana Paripalana Sangam in 2015, Best Award from Friend of Patients 2015, John Abraham Award for the Best Doctor 2014, and publications, more than 12 publications, and writer of neurology portion of Sarva Arogya Nigandu. Next slide, please. Professor Madhu sir, already I have introduced him. He's a great man. Professor and HOD of Neurology, Travancore Medical College Hospital, Kollam. Adjunct Professor of Neurology, Manipal University, Manipal.
We can skip the introduction in the sake of time, Krishmi.
Okay, okay. Thank you, sir. Thank you. Over to Professor Shaji.
Shaji. Shaji is there?
Sir,
I
I
think
think he disconnected. I'll check with sir.
Otherwise, we can start ourselves.
Sure, sir.
Yeah,
I'll
just we
connect
can.
in between.
Is he getting connected?
No,
Let us
sir,
wait.
not yet.
Not yet. Okay, then I'll just call him. അതെ ഞാൻ ഓക്കെ അപ്പം ഷായിക്ക് ഒരു കാര്യം ചെയ്യാം ഞാനെങ്കിൽ ഇൻട്രൊഡ്യൂസ് ചെയ്യട്ടെ എന്നാ ഒന്നുകൂടെ എൻട്രി ചെയ്യാനായിട്ട് ശ്രമിച്ചു നോക്ക് ഐ വിൽ സ്റ്റാർട്ട് ദ ഓക്കെ ഓക്കെ No, Lakshmi, Shaji has some problem in.
No issue, sir. You start, sir. We'll go ahead.
So I think Nitya, you can
Yes,
start present the history of the case.
Presenting the case of a progressive dysphagia and dysarthria. Presenting complaints, 55-year-old male, previously employed in the Middle East as a security personnel, presented with complaints of progressive difficulty in swallowing since 1.5 years, slurring of speech since 1.5 years, weakness of both upper limbs since 1 year, and sensory disturbance in the perioral region and oral cavity since 1.5 years. History of present illness. The patient was apparently normal till 1.5 years back when he noticed insidious onset, slowly progressive, difficulty in swallowing, motor liquids, especially while drinking large quantities of water from a bottle. It was associated with coughing and nasal regurgitation of fluids. 3 to 4 months after the onset of first symptom, he noticed difficulty in swallowing solid food like kubus. So, he made his food into a soft, compact, small bolus by mixing it with curd. This was progressive in nature, and at present, he is able to take semi-solid food by keeping the neck extended. Simultaneously, his friends noticed slurring of speech in the form of nasal twang in the voice. This progressed over a period of 1 year, and his speech became effortful with low voice. He had to take frequent pauses in between to clear the throat. 1 month after the onset of first symptom, his friends noticed deviation of angle of mouth to left side and drooling of saliva from the corner of mouth. He gives history of difficulty in inflating balloons and drinking juice with straw on special occasions. 8 months after the onset of first symptom, he also noticed loss of taste sensation to food and fluids. However, he could appreciate the hotness of tea and coffee. 1 year after the onset of first symptom, patient developed paresthesia around his right eye initially, which slowly progressed over the left eye over a period of 2 weeks and slowly descended down in both sides of face, perioral area and oral cavity over a period of 1 month. Along with this, he had difficulty in biting and chewing food, had difficulty in clearing food materials from vestibule. He gives history of painless recurrent ulcers in throat while eating food and used to get accidental bites of cheek and tongue. Once, the patient forgot to spit out mango peel and kept it in the vestibule without awareness and later aspirated it, for which he was hospitalized. Patient gives history suggestive of proximal muscle weakness of both upper limbs in the form of difficulty in doing push-ups, lifting heavy weights above the shoulder since 1 year. However, there is no symptom suggestive of distal muscle weakness of upper limbs or weakness of both lower limbs. No sensory symptoms pertaining to upper or lower limbs. Since 1 year, he had difficulty in keeping neck steady while driving and getting up from bed. Head tends to fall backwards, especially on sudden deceleration. Patient also noticed loss of contour of arm and shoulder in both sides. He gives history of twitching of muscles of left side of face, particularly while looking in the mirror since 8 months. No associated relieving or precipitating factors noticed by the patient. There is history of significant loss of weight of around 12 kg over the past 6 months. No other systemic symptoms. No history of decreased vision, double vision or hard of hearing. No history of headache or raised ICT features. No history of exposure to drugs, toxins or exposure to electric shock. No history of unsteadiness of gait. No other systemic symptoms. Past history, there are no comorbidities. History of a varicella infection 1.5 years back. Apart from a history of hematological malignancy for his mother, there is no history of neurological illness in the family. He follows a non-vegetarian diet, sleep and appetite normal, bowel and bladder habits were regular. He is a chronic smoker with a smoking index of 69. This is the timeline of illness. Since 1.5 years, there is progressive difficulty in swallowing and progressive slurring of speech. Since 16 months, there is facial weakness. Since 1 year, there is proximal upper limb weakness and loss of weight. And since 8 months, there is facial paresthesia, difficulty in chewing and clearing food particles from the vestibule. Summary: 55-year-old male, security personnel by profession, presented with insidious onset, gradually progressive dysarthria and dysphagia since 1.5 years, along with sensory symptoms in the face and oral cavity, followed by weakness of pectoral girdle, associated with twitching and thinning of muscles, with history of significant loss of weight. No history of symptoms referable to lower limbs, cerebellar or bowel and bladder involvement.
Okay, Nitya, Shaji.
Okay, I can hear, sir.
Yeah.
Can you, sir, can you go for the symptom analysis and all of this case? Can you hear me, sir?
Yeah, I can hear you. We cannot hear you. Yeah. So, shall we discuss the history now?
Yes.
Okay, then I'll share my. Okay, and Nitya, I am going to share my slide. You can unshare your slides. Then only I can share. Is my slide seen?
Yes. Can see, sir.
Yeah, okay. The same slide which she has projected. Just like our PG teaching, I'm acting like a PG now. I'm going to analyze one symptom after another. So the first complaint was in progressive difficulty in swallowing more to liquids, especially while drinking large quantities of water from the bottle. It is associated with coughing and nasal irritation of the fluids. That obviously suggests weakness of one palatal muscle indicating nasal irritation and difficulty in swallowing with coughing indicating a pharyngeal muscle weakness. So at this point of time, we know he has got palatal muscle and pharyngeal muscle weakness. Where is the site? We do not know at this point of time. 3 to 4 months after the onset of first symptom, he noticed difficulty in swallowing solid foods like kubus. And so he made into soft, that's all same thing only. It indicates only he has got a dysphagia, neurogenic dysphagia is present. Simultaneously, his friends noticed slurring of speech in the form of nasal tongue or voice, which indicate again a palatal weakness due to inappropriate close to the velar pharynx, so that the air will escape to the nostrils. That usually indicates a low motor neuron paralysis of the 10th nerve. This progressed over a period of 1 year, and his speech became effortful with a low voice. The effortful speech usually indicate a spastic speech or a spasmodic dysphonia, but effortful from the patient's own words does not necessarily mean it's really effortful or not. So under the context with other features of low motor neuron, it will be very difficult to envisage just by the history is like a spastic speech. I think we'll keep it separate till we got the findings. And he had to take frequent pauses in between to clear the throat, indicate that he has got a problem in swallowing, he's got aspirating in between. That is why he's taking frequent pauses in between to clear the throat. 1 month after the onset of his first symptom, his friends noticed deviation of the angle of mouth to the left side and drooling of saliva from the corner of the mouth, indicating that he has got a right facial weakness. It is more likely to be a lemon in view of the drooling of the saliva. Usually, human facial palsy does not produce drooling of the saliva from the corner of the mouth. He gives history of difficulty in inflating balloons and drinking juice with a straw on special occasions. Difficulty in inflating balloons and drinking juice with straw indicate that he's got a vaccinated weakness, but that does not necessarily mean vaccinated weakness in the present scenario, because if somebody has got weakness of the palate and cannot close the nasopharynx during swallowing or inflating balloons, the air will escape into the nasopharynx. So that will not make it possible. So in a person with palatal weakness, one cannot draw and inflate the balloon or drink from a straw, through a straw, even if the 7th nerve is normal. So that part may indicate a vaccinated weakness, but not necessarily be so in view of the 10th nerve palsy. 8 months after the onset of the first symptom, he also noticed loss of taste sensation to the food and fluid. However, he could appreciate hotness of the tea and coffee. So that indicates that taste is affected. So this is another point telling you that the lesion in the 7th facial palsy is likely to be in the 7th nerve. Element weakness first, and not in the human. Second point, it is likely to be in the nerve rather than the nucleus of the 7th nerve. The lesion is in the nerve. That's because the taste fibers are also affected. Chorda tympani is also affected. Now, 1 year after the onset of the symptom, patient developed paresthesia around his right eye initially, which slowly progressed over to the left eye over a period of 2 weeks, then slowly descended down on both sides of the face, perioral area, and oral cavity over a period of 1 month. So this apparently looks like that he has got involvement of sensory loss on the both sides of the face. One may, because in view of the previous history of most likely element facial weakness, one tend to think that this is most likely to be involvement of the 5th cranial nerve itself. But usual pattern in a one cranial nerve involvement, 5th nerve involvement in one side is that the upper part get involved, then the middle part, lower part, then the opposite side get involved. Involvement of the upper part of the face alone on one side followed by the other as initial manifestation of 5th nerve involvement is slightly odd, because how can it's very difficult to envisage that those fibers up to the upper part is affected first on one side, those fibers are on the other side, then the same fibers are affected over down. So this history does not usually favor a cranial nerve involvement, more like some other site of lesion. But however, this history needs clarification. But why I'm telling you like that, that kind of a pattern can occur if the lesion happens to be involved in the spinal tract or nucleus of the trigeminal nerve. So what I have drawn here is the spinal nucleus. As you know, there's nucleus got certain lamination. The fibers from the peripheral most part of the face descend down maximally. and into the lowermost or caudal part of the spinal nucleus. The middle part into the middle part of the spinal nucleus, and the in and around the perioral area reach the upper, into the upper part of the spinal nucleus. So all these from all these levels, it goes to the opposite side and from the ascending endothalamic tract. That is how the fibers are arranged in the brainstem. This is another type of lamination, like the upper part is descending and represented most caudally in the spinal nucleus and tract, and subsequently the lower part is in the upper part of the nucleus and tract. So this is the one that I already told. The lower part ends in the upper part, cross to the opposite side, ascend the opposite side. The middle part little more lower down, upper part the lowest. This is from the opposite side. See, if a lesion happens to be this is the crossing of the fibers from the upper face. See, if the lesion happens to occur at that area, so what the patient will have will be a loss of sensitive upper part of the face, just like our patient had. That one upper part is affected, then the other part is affected. So this would mean that the upper part is affected. As the lesion progresses upward, it encroaches upon the other crossing fibers. So what will happen? The sensory loss will descend down like this, just like the history given by our particular patient. So this particular point would favor a brainstem lesion, but the other points are not favoring a brainstem lesion. For example, Samdhanav is obviously not brainstem because taste is affected. Let us see the other finding, then before come to the conclusion. The next part of the history is that along with this, he had difficulty in biting and chewing solid food and a difficulty in clearing food materials on the vestibule. So difficulty in chewing and biting means the motor fifth is also affected. The muscles of mastication is affected. So that again a point favoring that the lesion is likely to be in the fifth nerve rather than in the brainstem. So for example, a brainstem lesion in the upper cervical cord ascending up cannot explain the difficulty in the motor fifth nucleus. So that has to be lesion in the pons or in the nerve itself. So this kind of ascending pattern of sensory loss does not go with or tally with the present finding of motor fifth cranial nerve involvement. So that's a point against brainstem lesion. He gives history of painless recurrent ulcers in the tongue while eating food and used to get accidental bites of the cheek and tongue. That is not surprising because he has got total loss of sensation inside the mouth. He does not know where the tongue is. He is very likely possibility that his tongue get injured while eating or speaking. Once patient forgot to spit out mango peel, so that obviously indicates loss of sensation or probably may indicate weakness of the tongue muscle because he's not able to pull out the mango peel from the vestibule. Then the next part is that it is going beyond the cranial nerves or beyond the brainstem, whatever it is. His history says proximal muscle weakness of both upper limbs, the difficulty in doing push-ups, lifting heavy weights above the shoulder since 1 year. If somebody has got a difficulty in push-up means there can be due to many things. Suppose the shoulder fixators are affected, like trapezius or serratus and subscapularis. They cannot do a push-up. Similarly, the extensions of the wrist is affected, like triceps, again, they cannot do push-up. So that difficulty only means that his shoulder muscles or scapular muscles are affected. That has to be clarified after examination. However, there is no symptom such to a distal muscle weakness, upper limb, say weakness, lower limb. Okay. So we know upper part, the proximal muscles of the upper limbs are affected. No sensory symptoms pertaining to the upper and lower limbs. Since 1 year, he had difficulty in keeping the neck steady while driving and getting up from bed. The head tends to fall backward, indicating that most likely the neck muscles are affected, mainly the neck flexors are affected because the neck is bending forward, going backward. And patient also noticed loss of contour of the arm and shoulder, both sides. Most likely that he has got loss of hypotonia or wasting, can produce loss of tone. We do not know what the loss of contour is without examination. If the shoulder is drooping down, it may indicate upper fibrous trapezius, elevator scapula affected. Shoulder has gone up, it may indicate lower fibrous trapezius affected. So that we have to, or deltoid loss can produce loss of contour of the arm. So those things can only be concluded after examination. He gives history of twitching of the muscles of the left side of the face indicate that again, showing that it's a clearly element weakness. The axons are affected or the nucleus is affected. And significant loss of weight may be related to the etiology, maybe because he has got a problem in swallowing. That is why he has got a loss of weight. Other things are negative history. This is also negative history. So this is a summary. So what is a summary from the history? What I am concluding from the history? He has got multiple cranial nerves are involved, bilateral fifth nerves, motor and sensory. Seventh is affected on the left side. Sorry, on the right side. No, on the left side. 10th is affected. 11th is probably affected. Probably 12th also is affected. And also probably neck muscles and proximal arm muscles. Now, where is the cytopathology? That is the next question. Since, see, if you find here, all the adjoining nerves are affected, close together. Okay, 9th, 10th, 12th, everything is affected. So if you find a pattern like that, adjoining nerves are affected, naturally we tend to think of a local, particular focal lesion there, like some kind of a mass lesion or a carpeting lesion, because it's encroaching upon one cranial nerve after another. Most likely pathology is that of a structural nature, like a mass or infiltrating lesion. Now, the first question to address if multiple lower cranial nerves are affected is that, is the lesion intraaxial or extraaxial? That means it's affected inside the brainstem or outside the brainstem. If extraaxial is a lesion, you have to find out whether it's inside the cranium or extracranially, outside the skull. Because all the lower cranial is also coming out of the skull to the foramen into the base of the skull. Now, let's first come to the first localization, intraaxial or not. Very unlikely to be intraaxial because there is, even though the multiple cranials are affected, he has no definite long tract signs. No pyramidal weakness, no long sensory affection, no Horner syndrome, no affection of any sensory tract which are located inside the brainstem. Moreover, affection of the taste along with the facial palsy favors a lesion is likely to be in the nerve rather than in the brainstem. And whereas as far as from get, there is no ocular muscle involvement from the history. The only point favoring intraaxial is that the descending loss of sensory loss over the face, suggesting the pattern of involvement here. But again, that is, I don't think that is valid here, even though that favors a brainstem lesion because he has got a motor fifth also is affected. So I think this part of history I will take with a pinch of salt, whether it's correct or not. The next step is to find out whether the lesion is inside the cranium or outside the cranium. The affection of the 7th, 9th, 10th, 11th cranium cannot occur in with the lesion inside the cranium and outside the cranium. But that is not possible here because he has got ophthalmic division of the 5th cranial nerve. That does not come out through the base of the skull. So it has to go through the superior orbit between the orbit. So the lesion is unlikely to be extracranial, it is to be intracranial. So where is the site? More likely a lesion in the clival region in the dura there, which can implicate the 5th cranial nerve as it go to the spinopalatal region, not spinopalatal, go to the apex of the Peters bone. A lesion descending down to the foramen magnum implicating the cranial nerves. Again, descending down to the the spinal roots can implicate the dura, can explain everything in this picture. So there are many things, some odd points are there that we'll discuss later on. Since the lesion did not produce any compression of the brainstem like a mass lesion, I would like to consider carpeting lesion in the meninges. Like, for example, pachymeningitis, etiology could be benign nature and we have the long duration there, like sarcoidosis, or inflammatory ceroid tumor like a IgG disease, or idiopathic, or some conditions like Wegener's granulomatosis, Jorgen's, etc. They can produce, they're all DDs of pachymeningitis. So that will be my history localization, the reasonable conclusion which I could make. I think I'll stop my slides.
Okay, sir.
Yeah, Shaji.
So we'll go to the, so it is look like a bilateral carpeting lesions history-wise. Shall we
Yes.
go to clinical findings? What are
Yeah.
the clinical findings?
Yeah.
Dr. Nitya, can you discuss the clinical findings of this patient? Dr. Nitya.
Please, I
Okay.
started sharing.
So coming to the general examination, he is conscious, oriented and cooperative, moderately built and nourished, BMI of 22.86, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. His vitals were stable. There were no hypopigmented patches. This is the photograph of the patient before the onset of illness, and this is his current status. Examination of the central nervous system, higher mental functions were normal. Speech, he had a slurring of speech.
We will present, I think. If sir wants some clarification, I think that time we'll show the video. Otherwise, we'll.
Yeah, I think, yeah, right. Because it's not, video is not playing very well.
Sir?
Yeah, you can go to the
So you
next
can
slide.
present if sir wants some clarification at that time, we'll put the video. Otherwise, we will
Okay.
lose the time.
Okay, go to the next slide.
So
Yeah, continue.
cranial nerve examination.
Yeah.
Cranial nerve examination. The olfactory nerve, it was normal both sides. Optic nerve was normal. Fundus was normal bilaterally. Oculomotor
Right.
nerves, that was normal bilaterally. There were no ptosis. Extraocular movements were full in all directions. Trigeminal nerve, the motor part, masseter, temporalis and pterygoids were weak on both sides.
Doctor, you can continue to present. Hello.
Yes, sir.
Yeah.
You can continue to present.
Examination of facial sensation in the or ophthalmic, maxillary and mandibular division. Pain, touch and temperature was decreased bilaterally. There were no graded sensory loss from the peripheral part of the face to the perioral region. Intraoral sensations were decreased bilaterally. The corneal reflex was absent on both sides. The patient was not able to perceive the sensation of cornea and bilateral conjunctiva. Conjunctival reflex was absent bilaterally and jaw jerk was absent. Should I play the video, sir?
Not necessary, I think. Yeah. Because the video is not playing properly. So it become very slow.
Facial nerve, the bulk is normal on both sides. Frontal belly of occipital frontalis normal both sides. Orbicularis oculi were weak on both sides. There were incomplete burial of burrowing of eyelashes. Buccinator was weak on both sides. Rhizoris, the angle of mouth is symmetrical on both sides. Orbicularis oris is weak on both sides. There was hyperacusis present bilaterally and platysma was weak bilaterally. Sensory part, the taste in the anterior two-thirds of the tongue was decreased on both sides. However, temperature is preserved bilaterally. Facial reflexes were absent on both sides. Bell's phenomenon was present on both sides. Corneal reflex was absent on both sides. The patient could not perceive the touch sensation. Conjunctival reflex was absent on both sides. Rinne test was positive with air conduction more than bone conduction. Weber was centralized. Uvula was central. Movements of palate were equal. Pharyngeal reflexes were absent on both sides and the patient could not perceive the touch sensation. Sternocleidomastoid and trapezius were weak on both sides. Hypoglossal nerve, there was symmetric wasting of tongue with fasciculations. Tongue movements were decreased and on protrusion it was deviated to left. Examination of motor system. There was symmetric wasting of the supraspinatus, infraspinatus, deltoid, triceps, biceps, brachioradialis on both sides. Fasciculation of facial muscles, bilateral triceps, brachioradialis and deltoid were noted. Here we can see the symmetric wasting of the supraspinatus, infraspinatus, deltoid, biceps as well as triceps. The tone in the upper limb, the tone was decreased on both sides. Lower limb, the tone was normal. Coming to power examination, neck flexion was weak and neck extension was also weak. Neck flexion more weak than extension. Supraspinatus, grade 4 power both sides. Infraspinatus, grade 3 power both sides. Pectoralis, rhomboids, grade 4 power both sides. Latissimus dorsi, grade 4 power both sides. Deltoid was grade 3 power on both sides. Biceps, grade 4 power on both sides. Brachioradialis was grade 4 power on the left side and grade 5 power on the left side. Triceps, grade 4 power on the right side and grade 4 power on the left side. Pronation, supination were strong on both sides. Wrist flexion extension was strong on both sides. Hand grip was strong in the lower limb. Both proximal and distal grade 5 power on both sides. Reflexes, superficial reflexes, corneal conjunctival gag reflex was absent. Abdominal reflex present on both sides. Plantar was flexor on both sides. The deep tendon reflexes were well elicitable on both sides. There were recurrent episodes of hyperkinetic movement in the form of lifting of both eyebrows spontaneously. There were no cerebellar signs. Gait was normal. Sensory system normal in upper and lower limbs. There were no peripheral nerve thickening. No spinal tenderness. Skull and spine normal.
You can summarize the definitive findings. That slide also you can show. What are the definitive findings?
The definite findings after the examination, there is a pure motor element weakness in the cervical segment of both upper limbs. Bilateral facial muscles, muscles of mastication, tongue muscles and pharyngeal muscles were weak, and there was bilateral facial and intraoral sensory loss.
Oh, Madhusudan sir.
Yeah, that I'll thank you. Can you, Nitya, can you stop the sharing? I will take from the things which have already been presented. I will skip. Now, I need 2 points in clarification. Initially, you said Georgic was brisk. Georgic's actually absent, no? Okay, that goes with the fifth cranial now. Then the another point which you mentioned that he had got a hyperacusis in this patient. That again points to the fact that the lesion is in the seventh nerve. So obviously the lesion is outside the brainstem in the multiple nerves are affected. Now, you did not mention about the sensory loss in the limbs and trunk. Is it there or not? I presume it is not there. So I go from that.
It is not there.
Okay, so as far as the cranials are concerned, the localization is same as we thought from the history. Involvement of the fifth, both motor and sensory, seventh, 9th and 10th, 11th and 12th cranial nerve. Here it is bilaterally affected. So state asymmetry is there. Now, next question is, what is the localization for the neck and postural muscles of the arms? See, does the pattern, when you get element paralysis, the first thing to find out whether the pattern fits in with the root, nerve, or the muscle or manual junction, or the anterior patchy involved anterior console. Here we not consider possibility of muscle and manual junction because sensory is there. Now, next thing is, does the pattern fit with the roots, nerves, or anterior console? The first thing which one should consider will be the root affection, because we are already postulating a lesion in the multiple base of the skull involving the multiple cranials in the base of the skull. So the lesion extending down into the spinal canal can implicate multiple roots. But you cannot think of an anterior console lesion in that context. If it had been a brainstem lesion descending down, we could have thought of anterior console disease. But there are more than one evidence to tell you that the lesion is not in the brainstem. So the what point here is that, now if the what is the point against the root lesion is that, suppose you want to implicate the roots, then you have to implicate C5, C6 and C7 root, because the triceps also is weak. But the other muscles supplied by the triceps is not affected. For example, the finger extension is aspired. So that you expect to be involved in a person with C1 radiculopathy producing a triceps weakness. Similarly, you said pronatus are weak, are spared, so also supinator. In the wake of weak deltoid biceps, and I expect the pronatus also to be weak if the lesion happens to be in the root. So that's a point against radiculopathy. Then one may consider anti-Honsel, but the gain of affection is exact. This pattern can go with anti-Honsel. I think again it's because the fasciculation has got a predominant wasting. The pattern is not fitting with the root involvement. So we can think of anti-Honsel. But my own reservation is that if you want to think of anti-Honsel, where do you localize? You have to localize the lesion within the cervical cord and the cervical cord. But if you localize the cervical cord, how to explain the involvement of the multiple cranial nerves outside the brainstem? That becomes very odd. So that means we have to choose one of the two. So which should we prefer now between CFSAC radiculopathy versus segment in this patient? I would rather prefer a CFSAC because taking the etiology into consideration, the cytoplasmic consideration, that seems to be more logical than an anti-Honsel involvement. So final localization after examination, multiple cranial nerves are affected, bilateral fifth nerve to 12th nerve. As regarded the neck and shoulder muscle can be either in the roots anti-Honsel. Since cranial nerves, it's already logical to think of a lesion outside the spinal cord in the roots rather than a lesion inside the cord affecting the anti-Honsels. So what could be the etiology now? The same which I thought from the history, some lesion extending from carpeting downward. The nearest possibility which can explain everything is a pachymeningeal lesion affecting the multiple lower cranial nerves and the upper spinal roots. The etiology can be idiopathic, sarcoid, Wegener's, Sjogren's, that comes later on. And that is my localization after examination.
So basically look like a carpeting lesion which is extending from the base of brain
Ah.
to the root, spinal root.
Yeah, that's the thing which you have to think about. But there are many odd points against that. I already told you the points against radiculopathy. But to explain everything by a single lesion, that's the thing which I have to consider.
Okay. Shall we proceed with investigation? We'll short of time.
Lishmi,
Yes,
you
sir.
want to invite other people to give an opinion?
Yeah, I think, sir, you are
Yeah.
the ultimate person, sir.
No. No.
No, not that way. But
Rashmi
then
sir,
I'll
you can give
I'll
some
just check
opinion.
up. I don't think there is any questions by any of the students, sir. So far, so good. There is no. I'll just find out, sir. Question
Okay.
answers. There's no open questions are there. No
Okay, right.
just raise their hand. So mostly they concur, sir. I think they are concurring.
Okay. Well, ultimately, I am flawed in this case later on. That I'll tell you later on. Okay, Shaiji, you can invite.
Shall we proceed with our investigations?
Yeah, please.
Dr. Nitya.
So we proceeded with the investigations. His hemogram was normal. Chest X-ray, ECG were all normal. The serum vitamin B12 levels were normal. All his viral markers, HIV, HBsAg, and HCV was negative. The tumor markers like serum AFP, serum CEA, serum CA99, serum PSA were all negative. So SPEP, that is protein electrophoresis, serum free light chain assay was also normal. The nasopharyngeal functional endoscopy was done, which showed a slightly inadequate tongue movement and sensation, leading to ineffective oral phase of swallowing, query due to muscular weakness. We proceeded with an MRI brain plus skull base with contrast with whole spine screening for this patient, and it was normal. There were no contrast enhancement.
Dr. Nitya, is there any basal exudate or pachymeningeal enhancement, leptomeningeal?
No, sir. There were no pachymeningeal
enhancement. One of our basal meningitis is one of our differential diagnosis.
Yes, sir. There were no pachymeningeal enhancement. There were no lesions in the brain. The report came as normal. We proceeded with the autoimmune panel.
One thing, cervical spine, everything is normal.
Yes, sir, everything was normal.
Spine. Okay.
The ANA was negative, CNCA, PNCA was negative. We proceeded with the paraneoplastic autoantibody profile, which again came to be negative. We did the ganglioside autoantibody profile, which was also negative. His CSF study was done, which was also normal. There were no malignant cells. This is the Blink study. He had an abnormal Blink reflex study with ipsilateral R1 and R2 were absent. R1 and R2 was also absent. This is the facial reflex study of the patient. Here we can see the orbicularis oculi is not recordable, but the frontalis, we have a potential suggesting a selective involvement. This is the EMG of the patient. Here we can see spontaneous potentials in the form of fasciculations. The EMG was done in the left biceps. We can see spontaneous potentials in the form of fasciculations. Here we can see large motor unit action potentials with a large amplitude. With delayed recruitment. The nerve conduction study was done, which was normal. We proceeded with USG abdomen for any paraneoplastic causes, and the urinary bladder showed a polypoidal mucosal thickening measuring 3.9 into 2.2 centimeter, noted in the right posterolateral wall of the urinary bladder with internal vascularity, possibly neoplastic. CCT abdomen was done, which showed the same findings of a heterogeneously enhancing polypoidal soft tissue density lesion in the right posterolateral wall of the urinary bladder, which features possibly suggesting bladder malignancies. The patient underwent TURP and complete resection of mass in the urinary bladder. This is the intraoperative picture. This is the histopathology of the lesion which was resected, which showed a high-grade papillary urothelial carcinoma with suspicious foci of invasion to the lamina propria. Muscularis propria was not involved by the tumor. The patient underwent 5 cycles of chemotherapy and 30 cycles of radiotherapy, after which he became symptomatically better.
What was the sensory condition? SNAP was normal.
Normal, sir.
Upper limb, lower limb. Okay. So, Madhu sir.
Yeah. No, and I already know the diagnosis. Given me the diagnosis. Now, see, this is a very intriguing case here, because I never thought it is a case of phosphine, as you are going to tell you. Because going back, there is one point favoring either a paraneoplastic or a something like a degenerative disease, is that the affection is symmetrical and selective. That's the only point. But think of a degenerative disease affecting sensory and entity concept is beyond my imagination. I couldn't think of a condition like this. But subsequently, when you I think you can tell the final diagnosis, then we'll discuss further on. Shaji.
Hello, Nitya.
Nitya?
So the final diagnosis was facial onset sensory and motor neuronopathy, FOSMN, as a paraneoplastic manifestation of carcinoma or urinary bladder.
In fact, this was an eye-opening case for me, but I had not seen it before. In fact, truly speaking, I today only saw another case, in fact, which I had seen much earlier. At that time, I did not think of that possibility. He had initially, that old man had, in that also present my fine program, he had presented with bilateral facial weakness, dysarthria, and he had absent corneal reflex, which I couldn't explain. So we did every investigation, everything was negative, even genetic test was done, which turned out came as a slow channel syndrome. But that now I know that that patient might have had a phosphine, because he had also had absent corneal. Now today he came for review. I checked his upper part spatial sensory loss, he has got bulbar involvement, and yet in EMG, he did not complain any weakness of the upper limbs, but in EMG showed denervation in the proximal muscles. So that is a very interesting case here. You can highlight on this case, Shaji, this particular presentation.
Dr. Nitya, can you show some review of literature? Actually, we are also initially, we are also get confused. This is like a, look like a, the syringomyelic pattern. Our clinical diagnosis was syringobulbia, even though there is so many odd points. That was our initial diagnosis. But as sir said, beautifully discussed, there is no definite point to suggest an intrinsic lesion. So subsequently, our investigation shows that all the there is no definite evidence of any pachymeningitis, no intrinsic lesion, nothing was there. The investigation shows there's a definite evidence of anterior horn cell involvement in the cervical segment, and there is evidence of sensory involvement, sensory neuron involvement of cranial nerves and motor neuron involvement. That was the investigation finding. So we went and searched the literature. This is a peculiar pattern. As Sir said, this started facial onset, start as a bulbar, then subsequently sensory onset in the face, that is spread bilaterally symmetrically, look like a extrinsic lesion. So this was our literature review. Total only 100 cases reported. There is a review of cases. That is for facial onset sensory motor sensory neuropathy. The peculiarity of this disease that why we should aware of such rare disease. Actually, this is a rare type of neurologic disease. Why we want to aware of such things? Because this has got a definite pattern of disease progression. If you remove the sensory compound, it look like a bulbar onset motor neuron disease. Exactly like a bulbar motor neuron degenerative disease. But the problem here is there is a sensory component also, bilateral symmetrical sensory component. So it is in a, the progression is in a craniocaudal direction. So there is a definitive pattern and fascinating the definitive pattern of disease progression from the cranial to caudal direction, and onset may be sensory or bulbar. In some of the cases, they start as sensory. In our case, start as a bulbar, subsequently sensory in a craniocaudal direction. This type of peculiar pattern is very important. And for recognizing this disease entity, that is facial onset motor sensory neuropathy, usually secondary to paraneoplastic degeneration, paraneoplastic manifestation secondary to malignancies. What they are selling, there's a selective degeneration of sensory ganglions of the fifth nerve, dorsal root ganglia. So also motor neurons of the cranial nerves. That is secondary to TDP43 proteinopathy. There is two group of argument. One school of thought is this is secondary to autoimmune process. Another school of thought is due to a part of degenerative disease because they demonstrated TDP43 protein in the nucleus. So still the controversy is going on whether it is primarily autoimmune or primarily a part of a degenerative disease. So the people tried various mode of therapies. Actually, we should remove the primary underlying malignancy if there is. We have to remove that. Then whether we should go for immunotherapy, immunomodulation, either with steroid or IVIG. In our patient, after removal of the carcinoma of the bladder, he automatically improved. Subsequently, we tried with methylprednisolone, and there was improvement after starting the steroid. There is improvement. We don't know whether it is primarily due to the after removal of this primary tumor or a part of a immunomodulation. We are not sure. Subsequently, we after course of steroid, we given rituximab also for immunomodulation. Anyway, he is doing well, and there is a much improvement with regard to this disease process. Now he's relatively preserved, and still he's on rituximab. One course is over. Now he's waiting for subsequent doses. Sir, Madhu sir, in comment, Lashmi sir,
Yeah.
Madhu sir.
Now, I also said literature subsequently. Now, as you said correctly, there are two schools of thought. Some of them favor a primary degenerative disease because paraneoplastics are not present all the time. Only few of them had paraneoplastic causes. Whatever it is, you have to err on the side of a treatable condition. You have to treat the immunomodulator, whatever benefit it gives. So with that case, I think I plan to give the same thing for my patient also. After
There in
Like
underlying
they-
malignancy in your case, sir, Madhu sir.
no, I investigated him because he came to for review only today. Today only I thought that question. So I would ask him to call him for admission next day.
Okay. Rashmi sir,
Yes, sir.
come.
Thank you for a wonderful case, sir. The first time, I'm also seeing this for the first time. I've never seen a case like this. And there are a couple of questions. One is in the etiology, should lymphoma should have been considered of? And how are the F waves in NCS?
The lymphoma can be considered if the lesion has to be a carpeting lesion. So if there is a carpeting lesion in the skull, you can definitely consider lymphoma as one of the etiology. But here the problem is already after we have made out the excluded a carpeting lesion, then we have to think of a paraneoplastic. Whether lymphoma can be underlying malignancy with the paraneoplastic syndrome, that's a great possibility.
Yes. And somebody has asked for the F waves.
Yeah, because the limb muscles are primarily it's an anticondylar disease. Unless the anticondylar is severely lost, the FA will be normal. Either on the two abnormality which you can find FA is the giant FA and the incomplete persistence of the FA in anticondylar disease. But here the only affection was in the proximal muscles. We usually do FA from the distal muscles of the upper and lower limb. So invariably it's going to be normal.
Sir, I'm sure that the entire.
Dr. Lakshmi.
Yes, sir.
Just,
Yeah, sir.
Welcome, sir. Welcome.
Yeah. First of all, I must say a little sorry from my side because I joined halfway down. But whatever I listened, it was a fantastic deliberation, wonderful case. And Dr. Madhu sir has given very eloquent dissection, and the case has turned out to be a fantastic learning. My compliments to all of you, and thank you for accepting our invitation. Another thing that I wanted to check with you, is there any marker antibody, because I missed that part. Was any antibody present in any paraneoplastic autoimmune range?
No. As far as I know, Shaji, is there antibody? I don't know.
No specific antibodies are not
Okay.
there. But all the other antibodies, what we are doing routine can be positive, but all these are non-specific, sir. There is no specific antibody. There is
And,
no marker for.
But in such type of cases where there is something overlap kind of syndrome or a very odd presentation, what I have learned and made a practice is to do early PET scan or early CT neck, thorax, abdomen, pelvis, so that the tumor part, because after going on a long route and doing all investigation, we have to just comment. I don't know what was the sequence of investigation in this particular case, but what is Dr. Madhu's opinion on how early we should get onto PET scan or elaborate CT scan of the body?
Obviously, sir. Yeah.
Huh?
But once you excluded a local lesion, local pathology there, the other possibility naturally you should consider is a paraneoplastic workup. And naturally, in that, as a part of that, we have to do a PET scan. The ideal thing will be a PET scan, PET CT, whole body PET CT. Because antibody may not be present in all the cases of a malignancy.
Actually, I just wanted to add, sir.
please.
And that should be done before genetics?
Yes, sir.
Should we do it before genetics or after? Isn't it so, right?
Yeah, perfect.
Yeah. Yes, Dr. Lakshmi, you were saying something?
Yeah. Sir, I see all the textbooks always say the numb cheek syndrome is one of the ominous symptoms. Whenever you see any sensory disturbances on the face,
Yes.
you have to go flat out to rule out any lesion. So recently, in fact, I had one person presented as numbness of the cheek, where the whole body PET revealed an intraparotid tumor which spread through the nerves. It spreads through the nerves. It is,
Absolutely.
and it is presented as so.
Yes.
The symptom, the take-home message is the sensory symptoms in the face. Always never neglect. That's very, very important.
symptom
Yeah.
which you have to do a thorough clinical
And-
examination and
Yeah.
especially.
Yeah.
Yes, sir.
A corollary to that, in fact, adding to that, numbness of chin and similar unusual syndromes, which we see combination of neuronopathy with something and all of them, they require early consideration of PET scan. That is my feeling.
Now, I may add that, Lakshmi, with that numb cheek syndrome or numb chin syndrome indicate a focal lesion in the mental nerve or in the nerve pathway. That, of course, this has to be any focal lesion. You have to exclude a malignancy or some like infiltrated lesion.
Yes, sir. Yes, sir.
Yeah, right. But the presentation here is a
Sir, this
diffuse.
is, I'm not saying this, sir, but what I'm saying is for the students to learn that whenever
Sure.
any
Right,
facial
perfect.
disturbances, you have to, when a focal lesion on the mental nerve, you have to go flat out to rule out.
Exactly.
That's exactly.
Perfectly correct, Lakshmi. Now, as Sudhisha was telling, when the pattern is fitting with something like a symmetrical or selective involvement of, for example, here, sensory ganglions are affected, motor neurons are affected selectively without touching the other long tracks, etc. Only selective involvement of those things in a symmetrical fashion. Always you have to consider something like a paraneoplastic or autoimmune etiology you have to consider.
Absolutely. Yes, sir. But
Thank
it
you
was
so much.
really great learning, wonderful learning. Thank you very much, sir. Sir, we learn every time from you a lot of clinical neurology. You are a wonderful teacher.
It is Shaji who was going to give me this input. I never knew this case before.
No, but the way you think and dissect, that is what is the learning. So, the thinking process that you initiate is really marvelous.
Thank you, sir. Thank you.
All
Lakshmi,
Sir, I think we can. Thank you so much, Professor Shaji and Professor Madhu, sir. If there is any other questions, there is Sudhisha, sir. I have answered everything, sir. I think
Absolutely. And
yeah.
my compliments to Dr. Shaji also and the team, whole team actually. And I'm sorry that I was stuck up somewhere in another conference which got delayed, so I couldn't join in time. Thank you very much once again to all of you.
I hand it over to the organizers to close the session. Thank you.
Thank you so much, sir. As we conclude today's episode of Secrets of Neurology, we extend our heartful gratitude to everyone who made this session a success. A special thanks to our esteemed course director, Dr. Sudhir V. Shah sir and Dr. Lakshmi Narasimhan sir for their visionary leadership. We are deeply grateful to Travancore Medicity Medical College and Hospital, Kollam, and Government TD Medical College, Alappuzha, for their invaluable support. Our sincere appreciation goes to Dr. Nitya Jose for presenting such an intriguing case, Dr. Shaji sir for their brilliant case dissection, and Professor M. Madhusudanan sir for his insightful summary and conclusion. And of course, a big thank you to all our viewers for your continued engagement. We look forward to welcoming you again on 31st January with another fascinating neurological case. Until then, take care and have a wonderful night. Goodbye.
thank you, Lakshmi.
Thank you so much, sir.
Thank you, Shaji. Thank you, Sudhir.
Yeah.
Thank you, Lakshmi.
Thank you so much, sir.
Thank you.
Thank you. Thank you, Sudhisha.
Thank you, sir. Thank you.